whatever I am showing you today is all about my experience in the last 18 years. And if you have to be successful in clinical dentistry, it's all about repeated experience, because that will reveal the whole, what you do on a daily basis. So these are some questions you ask yourself as to how and why are dental materials changing today rapidly. The techniques are changing. What have we learned from previous generation of materials? Most importantly, how does failure occur? And this is exactly what has led to biomimetic dentistry, because we all know most of the failures occur because of maximum preparation of tooth structure, and that's not the norm anymore. And more importantly, what are some of the best variables that affect our decision making and treatment decisions? And this is exactly what we will understand from the principles of biomimetic dentistry. So my goal for today is to inspire all of you and to be inspired as well. So this is how I started my journey. I met my mentor, Dr. Douglas Terry. We are still working together a lot. This is our first edition of the textbook, along with Dr. Ashwini, who was a critical part of this textbook. Shortly, we are very happy. We are going to work on the second edition of this book, for which we have already done a lot of cases in the last 1 month. We have done a lot of injection molding cases with injectables. So this is the guy who actually taught me what biomimetic dentistry is all about. And it still rings in my ears, because I remember I was a postgraduate student in 2003. And when I attended his hands-on workshop in Mumbai, that's the first time I met him in one of the meetings. And he said, after we finished the workshop, I spoke to him and I asked him, how are you so predictable in composite dentistry? Because as a postgraduate student, we were doing a lot of bonded amalgams and we had no clue how to work with these resin composites. And we were failing daily. And most of our restorations would come out in a couple of days. So that's the reason I asked him. And he said, if you have to be successful in any form of restorative dentistry, the core principle is you need to preserve sound tooth structure. And that's the key, because that leads to longevity. That makes your restorations more predictable. And the second principle, he mentioned it to me, is try to minimize micro leakage. Now, with whatever resin we work, we know it will shrink, it will leak. Now how much you can minimize, it's totally in operator's control. So that's why that's very, very important. And third principle, he asked me to work and be cautious at the tooth restoration interface, because most of your failures will start at this interface. And this is exactly what biomimetic dentistry is all about. Biomimetic dentistry is working towards securing a tight interface. Okay? So these are some principles which he mentioned to me way back in 2003, and now it's been almost 19 years, more than 19 years. And this is a very good criteria for us to follow when we do any kind of resin dentistry, any kind of bonded dentistry. If we have to learn from our failures, we need to look upon this FDA criteria, which will tell us how long our restorations are lasting, how are we predictable. And any restoration we judge from these three important parameters. One is an aesthetic property, functional property, and the biological property. So any restoration can fail in these three ways. If I see marginal staining in a couple of months in my restoration, that means it's an aesthetic failure. You cannot see marginal staining even in your simple class 5 restorations in 2 to 3 months. It's not acceptable. That means who is at fault? The operator is at fault. There is absolutely nothing with the material. There's nothing to do with the material. And if my restoration is fracturing or chipping in a couple of months, again, there's something which I have overlooked it. I have not handled my occlusion well. I have not layered my composites well. Maybe I incorporated a lot of voids when I was working. So these are some things which you need to look at. And no matter what, your restoration cannot fail from a biological viewpoint. And if it fails from biological viewpoint, that means it's quick. I mean, the patient will call you the next day that I have post-op sensitivity. So again, the operator is at fault. So this is for all the youngsters. Whenever you do any restorations, do a real good follow-up. So you know exactly what steps you're following, what's your technique, and whether it's working for your patients or not. So in your first years of practice, it becomes very, very crucial you do this follow-up to learn from your failures. And of course, these are dentist everyday challenges. When we talk about direct dentistry, when we talk also about edelweiss dentistry, it's all about shade matching, it's all about layering techniques, it's all about that finishing and polishing which we are lacking in our restorations. So these are the challenges which we can overcome with these kind of concepts, which we will discuss for the next 2 days. So what is biomimetic dentistry? Biomimetic dentistry, I can talk for the next 3 hours, but I'm just giving you a brief overview as to how you understand biomimetic dentistry. It's nothing but bioemulation, meaning to say you understand your substrates really well. When you understand your substrates really well, your techniques will fall in place. So you need to understand what is enamel, what is dentine, because on a given day you are working only with these two substrates when we talk about restorative dentistry. Okay, so just let me give you a little bit of insight as to what this structure is all about. And we all remember in second year of dental school, we learn a lot of dental anatomy and histology. So it all starts from there. Your biomimetic basics will start from there. It's all about histodifferentiation, morphodifferentiation. You need to understand how dentine is developing and how enamel is developing. This is mother nature. And there is something in between that is your dentino-enamel complex, okay? That's your DEJ. And that's one of the most important structure considered in biomimetics, okay? So I'm going to give you a little bit of insight. So from structural point of view, I'm sure all of you know this, dentine is more of organic, enamel is more of inorganic. Dentine has a lot of moisture, enamel has very less of moisture. So this is the difference we all know. But when I'm talking from a histological point of view, please remember dentino-enamel junction is the structural epicenter, which is connecting dentine and enamel. It is this structure which we lose most often when we are doing full crown preparations, okay? And when we are doing full crown preparations, we are losing a lot of enamel, a lot of dentine, and along with that, DEJ as well. That is why biomimetic comes into picture. So when I'm talking about enamel as a structure is something like it's like a protective shell. It protects the tooth under masticatory load. Whereas dentine is a structural dampening core, meaning to say it's quite flexible and it absorbs a lot of stresses, right? So if we lose a lot of dentine, but we have a lot of enamel, there's no point, because under masticatory load, enamel will fracture. But at the same time, if I have a lot of dentine and less of enamel, my tooth can still resist stresses. So these are some things which you need to understand. So why we need to understand? Because when I take you through the principles and the treatment concepts, this is the most important part. So now when you see, when you look at dentine as a structure, you see it's always concave. When it develops, it's always concave. Now when you look at enamel, it's always convex. So that is why there is a difference between how these two different substrates behave under masticatory stresses, okay? So just to give you a little bit of insight, when I'm looking at marginal ridge area, my dentine is always sharp, okay? And it is covered by nice rounded enamel. If I'm looking at my buccal and the lingual cusps, again, it's the same. It's rounded in enamel and sharp in dentine. If I am looking at my buccal surface and the lingual surface of a molar, my enamel is convex and my dentine is concave. So that's how the structure is. And that's exactly when we prepare a tooth, this is exactly what we need to follow when we're doing a lot of biomimetic dentistry. And of course, if you look at occlusal fissures, they're always present only in enamel, they're always absent in dentine. Okay, so these are some structural and surface correlations you need to do visually when you observe them. So now why biomimetic dentistry becomes so important for us? It is very important from a morphological and structural viewpoint because at the end of the day, it is all about biomechanics. If my restoration has to last, my biomechanics has to be in place. And it will be in place when I have all these two structures, okay, under stress. So I am just giving you a little bit of very important information. So if you see here, if I lose one marginal ridge, which is my most important anatomical structure, which will take up a lot of stresses, that means I am losing my dentine and enamel, okay, on one side. If I lose two marginal ridges, that means my tooth is now extremely weak, right? So what is the principle of biomimetic dentistry? Is try to maintain your marginal ridges as much as possible. Of course, you have no choice when the decay is completely undermined and it eats away all your marginal ridge. But there are instances where the decay is located in some areas where you can still preserve the marginal ridge. So that's how biomimetic principles goes about. So now the second most important structure we are looking at is on endodontically treated teeth. So please remember, biomimetics is not only with vital tooth. It's with endodontically treated tooth, it becomes even more important. So I am going to show you both the picture on the side. And if you see, the presence of intact roofs of pulp chamber is also very, very important. And most of the times we tend to lose the roof of pulp chamber when we are doing endodontics. So how we can mimic that and practice biomimetic dentistry is more important. So it is all about deflection, it is all about modulus of elasticity, it's all about the momentum, and it's all about the, the strength, okay? So it's all about the modulus of elasticity of my enamel and dentine and the respective restorative material which I'm going to use to mimic. It's all about the deflection of the cusp when I lose some amount of tooth structure, and it's all about the strength. So let's try and understand what are the changes we see in different situations. So if I have an intact tooth, for example, mandibular molar, under masticatory stresses, the cusps will deflect up to 1 microns only. Okay, that is acceptable. But say, for example, I lose 1 marginal ridge on a vital tooth if I do a class 2 prep. Then my deflection doubles. That means it is 2 microns. Why it doubles? Because I lost my structure on one side. Let's look at another situation. If I have an MOD, it's even more dangerous because now I lost 2 marginal ridges. That means my cuspal deflection can be 3.5 microns. So what is deflection? Is just the movement which happens because it lost the structure. Okay? Now let's look at endodontic access preparation. If I am doing an endo and if I lose 1 marginal ridge, my deflection goes to around 7 to 8 micron meters. And it's even worse when I am doing an endodontics and I have 2 marginal ridges missing. It's 12 to 17 microns. So now for me, restoring this tooth is more challenging than to restore a vital tooth which has 1 wall missing. So I'm just going to give you all the options as to how you can treat these cases in a very conservative way, because please remember, all endodontically treated teeth should not be crowned. It's not acceptable anymore if you have to follow biomimetics, okay? So just to give you a very good study done by Pascal Magnet, he did a nice micro-CT analysis, and what he compared was how much was the cuspal deflection on a natural tooth, on a MO cavity, on an MOD, on a slot. So he prepared, he measured the cuspal deflection, he restored, and then he measured the cuspal deflection. So if you see, on a natural teeth, there is absolutely no change. But when you move on from mesio-occlusal to MOD to slot, you see the most dangerous is MOD. When I prepare, I go up to 17 microns, and when I restore, the cuspal deflection still stays at 7 microns. So that's too high. But when I look at MO and a slot, it's quite okay, because slot is a more conservative prep. So it's about 5.4 when I prepare, and when I restore, I come back to 3.8. So this will give you some idea as to what happens with every kind of preparation you're doing on a daily basis. So the other important factor you need to consider, not only the width, the isthmus width, it's the depth as well. Okay, the moment our cavity depth increases, say I go from 2 mm to 3 to 4 to 5, that means my cuspal deflection will multiply by a factor of 8. That is why endodontically treated teeth is more challenging, because your depth is always more than, say I have on an average about 5 to 6 millimeters. On mandibular second molar with a fused root, C-shaped canal, you have more deep chambers. That means you're looking at 6.5 to 7 millimeters. So that would multiply the deflection by a factor of 8. So 2 things are very important. 2 things you observe, you read from the structure, the depth and the cuspal thickness, okay? So it becomes very difficult if you lose the cuspal thickness and if you are very deep. So that's a very, very difficult situation. But there are instances where your depth is less and cuspal thickness is slightly more, so that you can compensate by doing different restorations. And MOD on endodontically treated teeth, if it becomes deeper, it's even worse when you compare with vital tooth. So just to give you a little bit of information as to what is actually the difference between a vital and a non-vital tooth. When I was a student, we were told that non-vital tooth is very fragile, it loses a lot of moisture, it will fracture under load. But when I started to read a lot of literature, if you see endodontically treated teeth per se are not very weak when compared to vital tooth. What becomes more important is on an endodontically treated teeth, when you start losing a lot of tooth structure, that is more important than your access cavity alone. So try to make it a point that you don't lose too much of tooth structure when you're doing endo, okay? So basically you need to understand the changes in physical and chemical properties which can vary between vital and non-vital tooth. You need to understand the morphology and how it behaves under stress, and you need to understand the fracture resistance of these two situations. So if I am looking at chemical and physical properties, please remember it's all about collagen. And we all know in non-vital teeth, we tend to lose that collagen. So there is always some degradation over a period of time when compared to a vital tooth. So your adhesive bonding is much more predictable on a vital when compared to non-vital teeth, okay? Having said that, it's not that your adhesive bonding will fail quickly in endodontically treated teeth, but what happens is over a period of time it starts degrading, and I will show you what happens to the collagen and the influence on adhesion process. So if you look at this, okay. So first try and understand how much of collagen you have by weight on a vital and non-vital tooth. If I'm looking at crown, on a virgin tooth I have about 21.7 by weight, but on endodontically treated tooth at 2 years, it decreases to 20.1. On endodontically treated teeth at 10 years, it decreases to 16.8 by weight. So there is a dramatic reduction in the collagen by weight when you look from vital to endodontically treated teeth from an age perspective. When I'm looking at root, it's about more usually on a natural tooth, that's about 25.4. And on endodontically treated teeth, the reduction is not as significant as you see on the crown. So this is something you need to understand. So what becomes important for me in biomimetic dentistry is I'm looking at crown more than the root, okay? If I am looking at endodontically treated teeth right immediately after my treatment, there's not much change. But as you go from 5 years to 10 years to 12 years, you see there is a lot of degradation and it's all hollowing out. And this is when most of the teeth will fail. Most of your restorations will fail. Okay? So this is something you need to consider when you're doing any kind of restoration. And please remember, this is a very important statement. Collagen fibers don't have turnover. So the degradation has to happen. There's absolutely no way these hollowed out lesions will get filled up. Absolutely nothing can happen. So if I am looking at an endodontically treated teeth and vital teeth, as I said, the quality and quantity of remaining tooth structure is more important and not my access opening itself. If I do an access on a mandibular first molar with all 4 walls intact, I am losing only 5% of the strength because I have all 4 walls intact. I have no missing marginal ridges. My cuspal thickness is quite good enough. But say for example, you're working on a vital tooth now, no endo done, but you're losing 2 ridges. That means you're losing 60% of the strength of this tooth. So this is very interesting, okay? So again, as I said, it's directly related to the quantity and quality of remaining tooth structure. So now this is a very good paper for us to understand as to what's happening when I'm working on a vital tooth or a non-vital tooth. So this paper tells you from Messer et al., diminishing tooth resistance after endo treatment and conservative procedure. Imagine I do an endodontic on premolar, maxillary first premolar. I do an endo access with all 4 walls intact, meaning to say I lose only 5% of the strength. But say for example, I do the same thing with an endo access and 1 wall missing, I lose 46%. If I do access and I do 2 walls missing, 63%. So what becomes here more important is not the access itself, but the amount of walls you lose, okay? And also please remember, if I am doing endo, usually vital tooth has a protective feedback mechanism. It's all connected. So now if I'm biting at certain kind of pressure, my brain will tell me, oh, okay, stop, it's too much. But if it's a non-vital endodontically treated tooth, I lose this feedback mechanism. So this is called proprioception. So you lose the proprioception. And this becomes very important when you're working on teeth which are closer to muscles of mastication. That's your mandibular second molar. So please remember, don't overzealously prep your mandibular second molars and do a crown, because now this patient will lose the proprioception and you never know. And when we do zirconia, zirconia is very hard. So what happens to the tooth? Tooth is very brittle now. There's no support from dentine and enamel. So who's going to fracture? The tooth is going to fracture over a period of time. Okay? So non-vital tooth loses proprioception by a factor of 57%, okay, than a vital tooth. So these things are very, very important when you try and do biomimetic dentistry. Just to give you a little bit of more information, how I design my restoration. What are the important factors I consider on an endodontically treated tooth? Say, for example, this is one situation. Now, this is very interesting. There's a lot of research on this. On an endodontically treated teeth, if I lose one wall, okay, but I still have a lot of cuspal thickness all around. That means I have one wall missing, 3 walls remaining, correct? Out of the 3 walls remaining, now I need to measure my cuspal thickness. If my cuspal thickness is more than 3 millimeters, that's very good for me to do direct dentistry. I don't have to do any kind of a indirect dentistry. But if my cuspal thickness reduces less than 3 millimeters, then I need to worry because my cuspal thickness is less. Apart from that, I also measure the depth of my pulp chamber. As I said, depth will multiply the cuspal deflection by a factor of 8. So please, for every endodontically treated teeth, measure the depth. This is also a very important parameter for you to plan your restorations. But now what becomes more important is this kind of situation. Now, a question to be asked is, which situation is more favorable for us? Is it 2 opposing walls or 2 unopposing walls? So you will get these situations, correct? When you're working on endodontically treated teeth, you lose few walls. There is a situation where you have 2 good opposing walls, meaning to say, I have buccal and lingual walls, very good. Or one more situation where I have a buccal wall and a mesial wall. That means this is an unopposing wall situation. An unopposing wall situation is not a good situation. An opposing wall, where I have 2 good walls opposite to each other, this is a very good situation for me. So this will give me good longevity and predictability in my restorations. Of course, the depth of my pulp chamber also becomes very important. Okay? But if it's unopposing like this is dangerous. This is not good. Now I have to plan. I need to see what's my ferrule height, how much of width of ferrule I have, what is the depth of my pulp chamber, how can I restore this predictably, do I need a post? If I need a post, what kind of post? Do I need to reinforce with fibers? So these are some principles of biomimetic dentistry, okay, which I'm going to show you in due course of time. And of course, the other situation would be no walls remaining. That means you have only 2 millimeters of ferrule, which you are totally dependent upon for your restorations to last longer. Let's look at the rationale. These are some situations you will encounter daily on vital tooth or non-vital tooth. On vital tooth, we classify it as V1, V2, V3, V4. These are different situations. 4 walls, 1 wall missing, 1 wall missing, but the cuspal thickness is less, and then you have 2 walls missing with good opposing walls. Okay? When I'm looking at endodontically treated teeth, we classify it as E1, E2, E3, E4, E5. You can make your own classification. These are just codes. So if I'm looking at endodontically treated teeth, again I'm seeing presence of all 4 walls, 1 wall missing with good cuspal thickness, 1 wall missing with a lot of reduction in cuspal thickness, and then of course 2 walls and only 1 wall remaining. So basically what I'm looking at the spectrum is increased tooth structure loss as I go from E1 to E5. So what I need to consider now, once you finish your endo, it's not about just prepping the tooth, and most of them do that. In most of the clinics, this is how it goes. The moment they land up, they know that my patient has to undergo endodontic treatment, they're going to give them an option. Treatment plan is ready. Endo followed by crown. That is ridiculous. I mean, you have not even seen the structure of the tooth yet, okay? I would not promise my patient that I would do endo without caries excavation. I would actually tell my patient, after I excavate all the decay, that yes, you are an ideal candidate for me and you have good prognosis to go in for endodontic treatment. And then my restorative blueprint comes into picture. So I would do that by looking at certain local parameters. What are my local parameters? cavity size. I'm going to determine the size of my cavity. What is missing, what is remaining, how much is the thickness. I'm going to look at my position of cervical margins, whether it is supragingival, equi, or going sub, okay? If it is supragingival, it's a fantastic situation for me because that is what biomimetic dentistry is all about. Any presence of cervical lesions should not be overlooked. You need to see whether any premolar, if it's endodontically treated, does it have effraction? Does it have abrasion? So these are some things which you need to look into. And of course, most importantly, presence of cracks. Any cracks, cracked tooth syndrome is not an ideal candidate for you to do direct restorative dentistry. It's all indirect, okay? Also look at position of the tooth. As I said, for me, critical is mandibular second molar, okay? Mandibular second molar, maxillary second molar. Very easy for these two to fracture because they're very close to muscles of mastication. So position of tooth is also very important. So this is something I call as analysis of cavity factors. This is something you have to do after you finish your endodontic treatment. And what is analysis of cavity factors? You analyze what is missing, you analyze what is remaining, and you measure out of what is remaining, how much it is, okay? Based on this, you decide what's your restorative plan. All right, so now let's see what is more important for me. More important for me is interaxial dentine. That is why you see, after I finish my endo, I am going to measure my cuspal thickness. Where am I going to measure? Most of them measure at the tip of the cusp. That is wrong. Please measure at the base of the cusp. Why? Because that is the dentine I am looking at to preserve. That is my interaxial dentine. And when we do a full crown prep, full preparation for a crown, we lose all that. That is why now this tooth is not supported. Okay? Then what do I look at? I look at my interaxial dentine, my marginal ridges, interaxial dentine, marginal ridges, roof of the pulp chamber. So please read this structure, how much is remaining. And then of course, as I said, occlusal overload is something which you need to consider, and hard tissue cracks. Any tooth which you feel has more of occlusal overload, has a lot of hard tissue cracks, then your plan will change, okay? When I look at preservation of tooth, what's my hierarchy? There's something called as hierarchy. What is important for me and what is least important for me? What is more important for me is interaxial dentine, my pericervical, my periphery dentine around the enamel, and then of course least important is residual cuspal walls. And of course in between is the roof of the pulp chamber and the ridges. So these are your 4 important structures which you need to consider. As I told you, if you are working on a vital tooth, when you measure the cuspal thickness at the base, it should be more than 2 millimeters. If it is less than 2 millimeters, then you will consider cuspal coverage. Okay? Of course, we can do a lot of indirects. We can do edelweiss OVD, we can do Emax, that's your choice, but I will show you how we do edelweiss OVD directly in the patient. And of course, if it's an endodontically treated tooth, your limit is 3 millimeters. So there is a difference between vital and non-vital, 2 and 3. Okay? Don't forget this number. So basically, you classify your indications of doing biomimetic restorations into 3 categories. You have category A, you have category B, and you have category C. So category A means you have enough of tooth structure. Yeah, you have enough of tooth structure for you to do any form of direct dentistry. So it could be a direct veneer, it could be direct composite restoration on anterior or posterior. So when you look at these cases, you see I have a lot of enamel and dentine. So I don't see any reason for me to do a full crown, okay? Even if the tooth is endodontically treated, that's what I mean, okay? If I am looking at category B, this is where all your confusion starts. This is the dilemma now. Because if you look at this, tooth structure, that's a premolar, you see, there's a big hard tissue crack running horizontally. And this is exactly what you need to see. If there is a crack with 2 ridges missing, that means it's not an ideal candidate for me to do a direct dentistry. I'm going to look at my indirect options, okay? Similarly, if I am looking at this case, I have nice cuspal thickness on 3 walls, which are remaining. I have only 1 wall missing. I can still do direct dentistry here, okay? Now, the reason why biomimetic dentistry comes into picture is, please remember, anything you do in the mouth has to fail. There is nothing permanent. Nothing is going to last forever. Impossible. You're just trying to mimic what Mother Nature gave you, right? Now, you have to decide how you want your failures to be. after 10 years or 11 years or 15 years. So there are only two ways you can go. Your failures will either be favorable or your failures will be catastrophic or unfavorable. If I do crowns for all of these cases, then my failures will be unfavorable. That means I have no chance after 10 years to treat this patient again. It's just extraction and implant. So if you want your failures to be favorable, then you practice biomimetic dentistry. Okay, it's all in the mind. I mean, everybody thinks if I do a crown, it's much more predictable. Not always. Okay, and then of course there is category C, where I know I have a lot of loss of tooth structure. I need to increase my vertical dimension. I need to change the morphology of the tooth. Then of course I'm going to do a lot of indirect restorations. So again, as I said, you can make your own classification. Okay, looking at the case you have. And then cracked tooth syndrome, please always cover the cusps. You cannot do direct. You have to cap the cusp and protect the cusps, because what your objective is to eliminate propagation of crack by doing this kind of restorations. So these are some situations which you can encounter on a vital tooth, on a non-vital tooth as well. If you look, these are the two ends of the spectrum. If I'm looking on my left side, I have a lot of tooth structure remaining. I can actually manage this case just by doing direct composite dentistry. But if I'm looking on the other side, I have a lot of things to think about. Endodontics has been done, all the walls are remaining, but whatever walls are remaining are quite thin. So I have to protect the cusp. That means I will do an overlay in this case, but I will not do a direct composite. Okay? So when you have to make a choice, whether it's direct or indirect, please look at substrate, please look at structure. It's all about structure and substrate. Okay? That will decide your treatment plan. So just to show exactly what we do with the edelweiss concept by adapting this into biomimetic dentistry is just to show you a few cases, how we manage things. Of course, Desi already mentioned about color. With edelweiss system, the color comes from the composite itself, but you need to understand and color from a histological perspective. So please remember, there are only two substrates which gives you color. One is dentine and one is enamel. Dentine is the primary source of color. Enamel is the modulator, meaning to say enamel will just tell you how much of dentine you want to see. If you want to see a lot of dentine, the thickness of enamel will be less, and if you want to see more of dentine, the thickness of enamel will be more. So that's exactly what edelweiss veneer is all about. The veneer thickness on an average is around, say, 0.6, 0.7. You could reduce the veneer thickness from inside before you plan the case, and you can come up to 0.3. So then what happens is you see a lot of your composite chroma from inside. Okay, but if you don't want to see a lot of dentine, then you keep the thickness as it is. Okay, so in younger patients, we don't recommend you remove a lot of shell from the veneer inside. On older patients, if you wanted to see a lot of chroma, you can actually reduce it from inside, so you get to see a lot of composite from inside. So as Dieter Dietschi, who has worked a lot with this system in University of Geneva, he says very clearly that dentine core creates tooth color, and enamel is just a modulator. I mean, it's just about perception, how much dentine you want to see, okay? And we all know enamel generates translucency and opalescence. So basically, I'm not going through all this, but we all know chroma is nothing but the numbers, hue is nothing but the alphabets. So majority of our cases would be under A. 70% of the population globally falls under A. 22% are B, and very few is C and D. And of course, when you're playing with chroma, you play with the numbers. As you go from 1 to 3.5, you're going from low chroma to high chroma, okay? And of course, value becomes very important, and that's your final color, what you choose for your patients. And with your edelweiss veneer, whatever composite you're going to choose, that's exactly what's your value. So this is a very simple technique. This is called a button technique. Before you start using edelweiss veneer, if you really want to see what's your chroma and what's your value, you could do this. For value, please change your picture into a black and white. So exactly you know, because value can be measured only in black and white scale. And for chroma, you can place 3 buttons. So you have A3.5, A3, and A2. And please light cure them. This is extremely important. There are most of them who place the buttons, but they do not light cure. You know why? Because they want to use the same increment as the first increment. They don't want to waste composite. And composites will not give true color until you light cure, especially if they are camphoroquinone based. And if I'm not wrong, even edelweiss composites are camphoroquinone based, correct? There are only few composites in the market which are non-camphoroquinone, and that's Evoclar, because Evoclar has its own patented photoinitiator, that's evocerin. So most of the camphoroquinone based composites will actually darken a little bit once you light cure. So please don't judge them without light curing, because then it will be light, okay? And when you cure, it gets a little darker, and that's the real color what you will get in your restorations, okay? So basically when I am doing a veneer, edelweiss veneer on a lateral incisor on both the sides, so basically the preparation is all disease driven. You don't have to prepare as you prepare for a porcelain laminate veneer, because to do an Emax you need 0.5. To do an edelweiss you don't need 0.5. You can be 0.2, 0.3, 0.4 depending on the disease, okay, whatever patient has. And of course I would prefer a supragingival margin whenever a patient gives me that, but if a patient has a high smile line, then I have to go equigingival. At no point in my experience I would recommend subgingival margins to do this kind of veneers. So the preparation should be intra-enamel, you see. All your margins should be on enamel. That's the key, as I told you. That's the fundamental principle of biomimetic dentistry. The more enamel you have around the margins, you get more predictability, okay? Chances of staining are also less. So this is a completely intra-enamel preparation on both the sides. See, I see a lot of enamel there, a lot of enamel, and that's my dentine. And then once that is done, you have your veneer. Always whenever you manipulate with these veneers, don't use high-speed handpiece, okay? When you want to manipulate from inside, you want to change the shape, you want to get to the correct gingival profile, please use your micromotor at around 7,000 to 10,000 RPM with a football burr, okay? A nice diamond football, and you can cut it from, you can remove some composite from inside, you see? That's how you get a lot of chroma at the cervical third. So my advice is do only at the cervical third, because most of the patients' cervical third will be more chromatic. So now what happens is, I am using single shade, but my composite thickness at cervical third is more. So it's very simple logic. You can do this exercise. If you have an A2 composite, A2, I can make A2 look of different degrees of chroma with the thickness. So please remember, the chroma is directly proportional to the thickness of your composite. So if I use A2 at 2 millimeters and I use A2, the same A2 at 0.5 millimeters, A2 at 2 will look more chromatic than A2 at 0.5. So I can actually change that in my veneer. I reduce my cervical thickness. So now it becomes 0.2 millimeters. I can go maximum 0.2. We would not recommend go less than 0.2, because then the veneer itself will get very fragile, okay? So don't go less than 0.2. And then of course you have the opportunity or advantage of also changing the shape of the veneer, because every time you don't get the same shape of your patient. Some patients are too ovoid, some patients are too triangular, some patients are too squarish, okay? So you could change the shape with these veneers. That's the kind of advantage you have. And of course I would not recommend you to tamper the incisal edge area. Keep it as it is, okay? These are some things which you can work up with these veneers. So once that is done, you do the trying of the veneer. Of course, Desi will discuss a lot, but I'm just sharing my experience. And then of course, you etch the tooth for 20 seconds, you wash it off. You could also do 20-10 rule. For example, I have a lot of enamel around my margins, but for some reason my dentine is slightly moderately deep. So I'm not going to etch my moderately deep dentine for 20. So now the rule is very simple, it's 20-10. So you start from enamel, come on to dentine, don't stop, don't wait to see the watch, immediately start washing. So you're 20 and 10, you're more on enamel, less on dentine. So I'm going to wash it off, apply my universal adhesive, okay? Only your universal adhesives will work on dentine and not the veneer bond, as we discussed. You can use any adhesive you're using. Apply according to manufacturer's direction. Don't play with that at least, because they know the chemistry well. If they say 2 coats, gently scrub, do that. Some adhesives will tell you 2 coats, slightly agitate. Have you seen why they use those terms? Every manufacturer will not say apply. They will not say just apply. They will say gently scrub. One manufacturer will say slightly agitate. Okay? Now this is related to the pH of the adhesive. If your pH is too basic, I mean if the pH is 3.5, then you have to agitate the adhesive because it's not too strong. If the pH is 1.5, then you have to gently scrub. So please know your adhesives well before you start using them on your patients. And now I'm going to air blow to evaporate all the solvent, and I'm going to light cure. Okay? Now once that is done, I go back to my veneer, which has already been prepared. So cervical is very thin now. So since I used my football burr inside, I created a lot of smear layer, correct? That means it becomes imperative that now you etch the inner surface of the veneer with phosphoric acid for 5 seconds. So you condition the surface, you wash it off, and then apply veneer bond. Okay, this is hydrophobic, as you already know, and then I'm going to light cure this. This veneer bond is nothing but your enamel bond. You remember we used to use helio bond from Evoclar, if you remember. It was very clear to bond those crystal, Swarovski crystals. Okay, the same kind of adhesive. So I'm going to light cure, and then I'm going to use my edelweiss composite. Okay, now 2 ways you can use them. As Desi said, they are very, very high packable in consistency, they're high viscosity. So when you tend to roll this with your fingers, so with your body temperature, it's kind of acts as a heater. So it's going to become much more manipulative for you. Or you could also use a composite warmer. That's up to you. But if you roll it with your fingers, that's more than enough. And then you adapt it with your plastic filling instrument. So see, when I am layering this, you see very clearly it's thick at the cervical third. As I'm coming down, can you see the thickness of composite is varying? Please don't place it very evenly. Slightly vary your thickness, because I want more of dentine to be seen at the cervix, and I want more of the veneer to be seen at the incisal third. Okay? And now we place this. Now that's why it is very important you understand the inventory. Now not many people know what type of composites they are using. I mean, for them, every composite, from an optical point of view, it's same. It's not correct. So you have something called as dentine shade, you have body shades, you have enamel shades, and you have the effect shades. Now if you see how you understand well, if I place my dentine composite on a literature, can you see anything? Can you read? You can't. Why? Because we all know dentine is very good blocker of light. It does not allow light to transmit. So now when will you use dentine shade? Only when your tooth is discolored. If your tooth is discolored, now the patient comes to you, patient says, I want to change the color of my tooth along with the veneer. So that means my first layer on the tooth would be a dentine shade. So what happens is, when I place my dentine composite on the prepared tooth of my veneer, it will block light. So what I see is my veneer and my body shade. Are you getting my point? But if the patient says, do a veneer, but my tooth is not discolored, I want the same color, then I will use the body shade. So what you get from Edelweiss is all body shades. Okay? The only dentine shade what they have is AO. That's A opaque. So you could use an AO on the tooth, and on the veneer you can use any body based on your value and chroma. Okay? And enamel is already your veneer. Your veneer is already an enamel shade. But if you're doing direct dentistry, then you have a lot of enamel shades available. With enamel, there is a lot of light transmission. So I can read the fluoride so easily. That means enamel will allow light to pass through, it hits the body, and then comes back. Is it very clear? And body shades have chameleon effect. Can you see? You can still read something. All body shades have chameleon effect. That's the characteristic feature. That's why when we use A2, A3 in posterior, it doesn't matter. Everything matches. That's because it allows a little bit of light transmission. If I'm looking at translucent shades, these are all effect shades, 100% of light transmission. So we don't recommend you use translucent shades with Edelweiss composites. With Edelweiss veneers. You could use their tints, which is available, like effect blue. Because using translucent composite in thin sections is not very easy. You might be sometimes too translucent. Okay, then everything looks gray. Okay, so that's why it's important you understand this. And this is a very good example as to how you can modulate your dentine. If you see, I have 4 discs of enamel, 0.3, 0.5, 0.75, and 1 millimeters. Now what you learn from here is, the moment my thickness of enamel goes beyond 1 millimeters, that means now my restoration everything looks gray, because light transmission is really high now, because my thickness of enamel is more than 1 mm. That's why you see the Edelweiss veneer on an average, it's around 0.6 to 0.75 mm. Okay? For some reason, as I showed you in one of the case, if you want to see more of dentine, then please make sure your enamel is very, very thin. Okay? But at no point you are going beyond 0.75 millimeters. Yeah? So we published this paper in JCDP when I was in the university. And of course, now I place the composite in my veneer. So here what I'm showing you is And on one place, I'm using a body shade. Can you see on the left-hand side? On the right-hand side, I'm using the enamel shade. So if my patient is too young and if they want bright teeth, I can use directly my enamel. Okay? Provided my preparation depth is not too much. You got my point? So I would recommend your right side using enamel in your veneer only in a no prep case. Okay? But if you have prepped the tooth, then of course you need a lot of body shades. Yeah? And then you place it, and then you modulate it along with the mylar. And here the critical part is, and you will see this today in the live demonstration, and I would recommend, this is what I learned from Stefan, because when I started using edelweiss veneer in 2013, 10 years back, I really struggled in this area. And this is when Stefan told me that it's pretty easy. I mean, everybody who sees a veneer will say, oh wow, it's a piece of cake for me. It's easy, I just have to bond it. But the most important point is working at the interface. This is what I told you. All the failures will start from the interface. So what's my interface here with my edelweiss veneer is my veneer, my composite, and my tooth. Okay? And where will that interface be? Cervical and proximal. So please, when you place this veneer, you will see a lot of composite coming out, squeezing out from the proximal. Now what you have to do is, you take a thin blade instrument and push all the proximal composite inside, proximally, as much as you can, and then use your mylar and work at that interface. So you will not get marginal discoloration. Otherwise, at the margins, it will discolor. Then don't blame that edelweiss veneers are discoloring. It's again an operator error. Okay? So anyway, tomorrow in the hands-on, you will learn this. And then most important point is, when I do this, first thing, please do only tack cure. What is tack cure? 3 seconds, you're going to cure at the incisal edge, through the incisal edge. Why incisal edge? So that my proximal and gingival composite doesn't cure. I can easily remove the excess after 3 seconds. Don't make that mistake of curing directly like this. Then you have no choice. You have to use a diamond, and that is not acceptable. So cure it from the incisal edge, 3 seconds. Veneer is stabilized now. Start removing all the excess. Start packing wherever there is deficiency. Use your mylar effectively, and then you polish these areas. Okay? Now once everything is done, you full cure. And now what we do is, we polish only the marginal ridge areas, the margin areas. And now you see the veneer looks seamless, extremely beautiful. So just to show you a few more cases, this is an absolute this is a very minimal prep case. We use pumice. You can also use rubber dam. Of course, rubber dam is always preferred, but if you can control it without rubber dam, that's your comfort zone. But I would always prefer a rubber dam. You could use an air particle abrasion to improve your bond strengths, especially with these veneers. Of course, I do this when I have a lot of enamel. So, okay, this improvises my bond strengths. This is basically 50 microns alumina. So you use it at 2 millimeter bar pressure just for 15 to 20 seconds. And then one more important clinical tip. Whenever you start to bond the veneers, please use a proximal strip and finish your proximal areas. Because sometimes you see there are a lot of staining around the proximal, and that could become visibly evident when you finish your veneers. So please make sure you finish your proximal areas as you are preparing the tooth, and you see the margins are supragingival. Don't break the contacts. Go very close to the contacts as possible. Now my prep is completely on enamel. Okay, then I'm going to etch, I'm going to wash, I'm going to apply my adhesive, same steps, and then I'm going to start placing the veneers. Okay, one by one. Whenever you're doing canine to canine, preferably go with 2 centrals first, then 2 canines, and then do two laterals. Okay, that way you can control easily, because don't go central, lateral, and then suddenly canine is slightly larger. Anything which is small you can control very easily. Okay, load the same way, tack cure. You're going very quickly, and see this is how it is. See, that's why if you see here, the margins are not great here. Can you see? This is something you will encounter in most of these veneer cases. So these are the areas you give little more time to finish and polish. Okay. So basically see my burr is touching only the margin area. You cannot touch the laser sintered glazed area. Okay. Of course you can do that if you want to give a lot of textures, which I will show you, but it's not recommended unless and until you want to give textures. So only at the margin area, labial and lingual, and then polish only the margin area. Okay. Finish the proximal areas with finishing strips, and then finally you can polish. If you want to use something on the surface, then it's only a high gloss polisher. You cannot use a finisher. Is it very clear? Okay. And this is exactly the patient is after we finish. So from here, we go here. So what we improvised is we improvised the whole smile. We got the laterals out. We also worked on those demineralized areas. You can see at the canine, at the lateral. So everything is pretty nice now. Nice emergence profile. Always see from the incisal view. Emergence profile is very, very important. This is your height of contour. So please see from the incisal view, because the advantage with these veneers is you can correct it later as well and polish it again. This is one case, we did it here. Stefan and me, we did it here. I think he remembers, you have the video as well. He came for one of our course. He is a prosthodontist. He's heading the implant department in Yanapoya in Mangalore. And he was here for the training. And you see, as a prosthodontist, it's all about ceramics. He never did composites in his life. For him, it was all ceramics. And when he came here, he showed us his two laterals. Can you see his two laterals are direct veneers? And in his university, these direct veneers were done 6 times. Every 3 months, it used to discolor. Now, the problem is they did not finish and polish well. So you see a lot of marginal discoloration. The surface is not great. And then Stefan very minimally invasively placed the veneers, edelweiss veneers for 2 laterals. And I think he took only about 30 minutes. I still remember he started when everybody was partying here, the champagne and whiskey and wine, and Stefan was working, and he finished in 30 minutes. He started at 6 o'clock, he finished at 6:30, and then we went for dinner. And this is the post-op. From here, he landed up here. And if you see the surface now, you see from here, we reach here. Fantastic. And you see, it's been 4 years now. The surface is still like that. Whenever I meet him, whenever he's in the conferences, he says, man, your edelweiss veneers are working. So the surface is really, really good. And this is exactly how it looks. You see? And now he's always smiling. And he is the first one to start using edelweiss in his practice. You see, when something is in your mouth, you start to believe in that concept. So he's working a lot with these veneers. Of course, he's also working with one of the CAD/CAM project for edelweiss. So because they have the CAD/CAM systems in their universities. Of course, some cases like this, you can quickly finish. These are long neck veneers. Edelweiss also makes long neck veneers. If you have certain cases, you can inform them. They will, because it's not available very routinely, but if you have long neck veneers, you can tell them, they will make it for you, especially for recession cases, okay? Now, if you want to work on the surface, if you want more surface texture, you can do that on these veneers. Now, why textures are important? Because certain young patients will come to you and say, for example, the textures of edelweiss veneer is not matching to the adjacent tooth. This happens usually when you're doing single veneer. If you're doing a single edelweiss veneer, then you have to be very right with the match of your textures, okay, and the surface gloss. So you could do that. Once you have bonded it, what you can do is, if you see here, I have 2 central incisor. I can see those developmental depressions so clearly. Can you see that? If you want to exaggerate that on the veneer, you could do that, and you could get the same polish. And this we will show you in the hands-on tomorrow. Okay? So that's one more advantage you have with these veneers. So how you do this? It's very simple. After you finish this case, for example, very quickly, now what you do is, let me show you. Okay. One more important thing. Say, for example, you have multiple class 3s like this, and you want to do an edelweiss veneer. You can still do it. But when? Only when you modulate your tooth with direct restoration. So first, you will restore all the defects with direct composite, and then place your veneer on the top. Don't expect the veneer to fill all these areas. Okay? You could also do for a large class 4. Get the lingual shell, and then modulate, make your mammalions. So these are called layered restorations. You layer it, and then you place your final enamel. Okay? So there are a lot of possibilities what you can do. Of course, you need to understand what case you're working on. And then, for example, now let's look at how you do on surface morphology. Okay? Yeah. Now, why surface morphology is important? You need to understand the rationale. If I don't give surface morphology and all my restorations are flat, then whatever strikes on the tooth, the light will go in the same direction back. So now the opposite person looking at this tooth would say, something is fake, I don't like it. Okay? you have to give surface texture, so when light strikes on the tooth, they don't go in the same direction, okay? And for your information, most of the edelweiss veneers, what you have, they are already a little bit characterized, but you have an advantage of characterizing it more if you want, okay? Of course, when you read the patient's tooth, and you will see textures only at certain angles. You might not see textures directly with a 6 o'clock position. So you have to come either a 3 o'clock or a 9 o'clock position. You come to the side of the patient or you go behind the patient. So 12 o'clock position is a very good position to map the textures. And once you know you have textures like this, you can actually exaggerate them on the veneers, okay? So how we do on the veneers is something like this. You mark it on the edelweiss veneer, it's already bonded. And now you mark it with your pencil. And now take your round burr in a slow speed handpiece. You could also use rubberized abrasives, okay? Nothing is going to happen to this veneer. Once it is bonded, it's very strong, it's not fragile. And now you start giving those textures. So you map it, you trace it, and you replicate it, okay? It's pretty easy. And then you repolish it. So that's the biggest advantage you have. So see, these are the kind of textures you can achieve with these veneers. And this is one of the cases I wanted to just show you because I was mesmerized by this case done by Stefan. This is a 9-year-old recall, if I'm not wrong. This is how Stefan did this case. And after 9 years, the veneers are still intact with no marginal discoloration, no wear. Of course, if you see the close-up, of course, anything, whether it's ceramic or composite, can dull a little bit. But there's absolutely no demargination, no marginal discoloration, okay? The tissues are in good health, that's more important. This is predictability. This is how we started, this is how we ended, and it's 9 years now. Of course, occlusion VDs, Desi will discuss tomorrow, but I just want to show you one thing very quickly. Let me just skip this. Okay, yeah. Where can you use occlusion VD and how you prepare the tooth to use the occlusal veneer. Now, there were some challenges when we launched this in India. Dentists had no clue. I mean, they were very excited that we have occlusal veneers, which nobody has, okay? You have the tabletops ready for you to do. You don't have to depend on the lab. But the problem was they had no idea as to how to prepare the tooth because they were not assessing the thickness of the occlusal veneer. So please remember, it's logical, it's common sense. Your tabletop has a certain kind of thickness, correct? How do you compensate that thickness? By prepping the tooth, right? If you are raising the bite, then of course, it's a no-brainer. You don't have to prep the tooth. You can just roughen and place it. But if you're not raising the bite, if you're doing a single OVD, then it becomes very important that you understand how to prepare the tooth. And nowadays, it's not traditional preps. It is MDPT, morphology-driven preparation technique. This is biomimetic dentistry. So I'm just going to give you a very simple clue. Rule number 1. Only prep when there is defect. What is defect? What is defect or what is necessity? You will prepare only when it is necessary. Necessary means when the cuspal thickness goes less than 2 mm. It's a necessity because I have to cap the cusp. I have to protect the cusp. Okay? Something like that. If there is a hard tissue crack, it's a necessity. So now, second thing, most importantly, margin design. In MDPT, it's not traditional. You don't give a 2 millimeter butt joint, okay? Nowadays, it's not 2 millimeters, it's 1 millimeter. So there is something called as butt joint, there is something called as inclined plane or long bevel. So these are the two margins you're looking at when you're doing these kind of veneers. So when will you give butt joint? When will you give inclined plane? Every tooth has a height of contour. Please remember, that is called equator, okay? That's always in the middle third of the tooth. If your defect is below the middle third, okay, near to the contact area, that means now you're below the equator. So your margin design will be butt joint. If your defect is above the equator, something between coronal and middle third, that means now I'm above the equator, my margin design is an inclined plane or a long bevel, okay? So these are two scenarios. So see, that's my inclined plane, that's my butt joint, that's my inclined plane. You will not give a butt joint here. Remember, if you give a butt joint, what will happen? You're going against biomimetic dentistry. What is there? If you give a butt joint, you lose what? Dentino-enamel junction. Now you understood? Only 1 millimeter inclined plane, that's more than enough. Whether you do edelweiss OVD, whether you do an Emax, these are the principles. Okay, don't shy away from this. This is extremely important. Now, what is more important is something called as transition zone. What is a transition zone? Remember, on one tooth, you are giving how many margins? 2. But and something is joining them both, correct? That is the transition zone. So you're going to slide that. That's the third design, slide. Meaning to say, from inclined plane to my butt, it should be a very smooth flow. It should not be a ragged edge. Okay, it should be gradual, continuous transition from my bevel to my butt joint. Okay, if you don't manage this transition zone well, then your digital scanners will not pick up or your impressions will have drag. Okay, so this is very, very important. So then you finish your preps. So that's my slide. I finish. I check the space. Minimum required now for my occlusal veneer from Edelweiss is about 1.2 millimeters. So at the marginal ridge, I'm going to remove 1.2. On my occlusion, I'm going to remove 1 mm. That's enough. That's minimally invasive. Okay. So this is the principle of MDPT. You should not forget this. Occlusal anatomic reduction, butt joint if it is below the equator, hollow long bevel above the equator, and please connect the planes with a slide. That's your transition zone. Okay. So for a single tooth, this is the kind of preparations you will do. So these are the kind of preparations. You don't break the contact, you see. Butt joint, inclined plane, nice transition zone with a post. You see, I have everything in place. Yeah. So what we did was, this was done by Ashwini before she came here. We quickly did this on extracted tooth. And it's doable. You see, you have a butt joint, nice inclined plane. But what I want you guys to see here is, apart from the preparation, please don't ignore the substrate. Now, can you see here? This is just a depiction. Just we wanted you to see. I mean, we will work on this in a much better way, but this was very quick, so we just wanted to show you. If you see now, you have dentine, correct? Okay. On one side, you have caries affected dentine. On other side, you have normal dentine. Now, please remember, whenever you bond, all the adhesives are made to work only on sound dentine. Okay? On caries affected dentine, your bond strengths are always compromised. Right? So you have to alter a little bit. So what I'm going to do is, I always will roughen the caries affected dentine with my diamond, and then I do my bonding protocol. That will improve my bond strengths. Or I could use my air particle abrasion. Okay? So please don't ignore the substrate with your structure as well. And then of course we follow all the principles of MDPT. We nicely give long bevel, don't break the contact here. There was a defect here below the equator, we gave a butt joint, and see again we followed it up with inclined plane. Okay, and then that's my occlusal veneer, that's my tabletop. You check the fit, it's nice and fine. You can use the adhesive stick to do that, or you could hold it with your fingers, that's up to you. And then what we do is we follow the same bonding protocol, etch and bond on the tooth, veneer bond on the occlusal veneer. And we do a lot on endodontically treated teeth, on single endodontically treated teeth. If I have my 4 walls intact, it's the easiest restoration for us to do, and it gives predictability. And it's totally in your control. You see, you are not dependent on the laboratory. You do it quickly. I mean, you finish the endo, you could do it quickly. But again, one more important thing is, let me go back. When you do your access openings, please remember there is something called as cavity dentine optimization. You have to optimize your cavity configuration. You cannot do an OVD with your access cavity 5 mm hollow space. Meaning to say, after I finish my obturation, I'm going to etch and bond, and I'm going to optimize my geometry, cavity geometry, and get it to a level where I have 2 mm of space remaining. I can't have more than 2 mm. Is it very clear? So optimize it with any of the bulk fill composites available in the market. Okay? You could use a bulk fill SDR, you could use anything. Okay? And if my cusps are weak, then I have also the option of using my fibers and reinforcing them with my bulk fill. Okay? So this you have to do. And then of course we try in the occlusal veneer from Edelweiss. We use the same composite as given by Edelweiss. That's my A1 shade. And then I'm going to place this. You see how the composite excess comes out. Okay? Give a gentle pressure and then do tack cure. Tack cure. Just move your light for 3 seconds around and then remove all the excess. Again, please remember, you're getting a lot of interface here, correct? This is where I'm working on. See? Seamless, absolutely seamless. And it gives you very good aesthetics because of the body shade, because body shades have chameleon effect. And I'm showing you this on an extracted tooth which is discolored. Ideally, it should have been cleaned, but I'm just showing you how the effect is. On a vital tooth when you're working, or even on a non-vital tooth when you're working on patients, it's absolutely seamless. Okay? And then of course you finish only the margin areas. Only the margin areas. You will not touch the occlusion. I will touch the occlusion only with my 200 microns articulating paper. Check my contacts. If there are heavy contacts, I'm going to reduce that. And then I'm going to use my 40 microns, check the high spot. I'm going to reduce that with my red ring football and then polish it. That's it. Okay? And I'm going to use my gray one. You will use this in the hands-on tomorrow. That's my gray polisher. And see, the best part is the seamless integration. Absolutely seamless, nice anatomy. And of course, in some patients, it depends on the opposing. Okay? Now the anatomy, what you see is nice, and you have all the cuspal inclinations, you have the grooves, but it depends on patient to patient. If they have good anatomy on the opposing, then you have this. But if they have a flat anatomy, then you have to make this flat as well. Okay? So this is something you need to, then don't get a little agitated that I lost all my anatomy. That's fine. I mean, for me, this is more important. Okay? So just to show you a video on CAD-CAM, Edelweiss CAD-CAM, how to bond them, because there was a question when Desi was doing, just let's see quickly. 2 walls missing on a premolar. I'm going to remove my Gadaperka because any endodontically treated teeth with 2 walls missing, I am going to place a post, okay? Not to strengthen the tooth, but to retain the core, okay? I have no choice. So when you do a post and core on an endodontically treated teeth, posterior teeth, the length of the post doesn't matter. You could actually have a short post. It could be a 6 or 7 millimeters from the orifice, because remember the forces are along the long axis. So it's much more favorable. Whereas anterior, I need 10 millimeter post because the forces are oblique, okay? So bonding protocols remains the same. In this, you also have an option of using Edelweiss post, but in this case, you can't use Edelweiss post and core, which is already with the core, because I have a lot of walls remaining. So we don't recommend you that you break all the walls and then use Edelweiss post and core. Edelweiss post and core is only for situations where all 4 walls are missing and you have only 2 millimeters of ferrule, okay? And then of course, we changed the bond to dual cure in the canal. We placed this, and in this we did Edelweiss CAD-CAM overlay, just to show you how we bonded it. Once we finish the post and core, you could use any core build-up material, dual cure as a luting agent. So you inject in the canal directly, always bleed, so you know exactly what's the setting time. Now I go into the canal, inject, keep the tip in constant touch as you're coming up so you don't incorporate air voids. Now place the post, build the core, and then prep the tooth following MDPT, okay? I am doing an overlay, no crowns. We don't believe in crowns because my margins have to be supragingival, patients can keep it clean, it's much more predictable. So once I finish my core build-up, I'm going to light cure, okay, for a minute at least, 60 seconds, remove the auto matrix, and now start prepping. Follow the same. You saw the defect was where? On both the sides, below the equator. So it will be a butt joint. But whereas on the buccal and lingual wall, it's only an inclined plane, okay? And then you have the transition zone. So that's my butt joint on both the sides, inclined plane. And then we scanned this. We got the Edelweiss CAD-CAM overlay back. You see, nicely polished with nice staining from the laboratory. And now you have the option of using 2 things for bonding. I would not recommend resin cement. I would use a composite. But say, for example, if you're not very comfortable using composite in the form what Edelweiss gives you, what we did in this case is we warmed the composite. And you see, it became so easy. So you can preheat these compules at around 60 degrees. And now we have a heater which has an inbuilt in the gun. Okay, it's not like a heater where we heat and then you come out. Okay, now these heaters, the disadvantage is if it is 60 here, when you go into the tooth, it's 5 degrees less, so it's 55. But whereas if I'm using a gun which is already inbuilt, I'm going, it's a real time, so I'm going with real time warmer. So again, etch and bond, we always recommend adhesive approach because these are non-retentive preps, okay? Always etch and bond. And see now, this is my preheated composite. You see the viscosity, how it changes. It's so easy to remove, okay? So remove all the excess. Tack cure. After tack curing, please use the floss to remove the proximal excess, okay? At the same time, please hold it because you have not cured it. And once you remove the proximal excess, you cure it completely from all the sides, okay? So preheated composite is what I would prefer if you're not very comfortable with the highly viscous composite which is available, okay? And see, seamless. Now this is what we like. Where is my margin? This is biomimetic. I have my interaxial dentine intact. Now the question is, even this will fail. I know this will fail, but when it fails, it's favorable. What happens is when it fails, I have the structure still intact, but that will not happen when you do a full crown. Okay, so that is biomimetic dentistry. So where is restorative dentistry heading? You have to make a choice what you want to do, direct, indirect. And as I say, all restorations you do will have some gray areas, okay? But it's more important you follow the standard of care and always have some science behind your technique. It's not about just doing whatever you like in the mouth. So as Edelweiss says, it's very close to nature. I mean, they have science, they have backing of science, which you will see in the next 2 days, okay? So as Pascal Magnus says, what is biomimetic dentistry? It's preservation and conservation. If any of your restoration has to be predictable, then you need to balance 5 important parameters for any restoration. And Edelweiss gives you that option. You can balance biology, mechanics, adhesive, functional, and aesthetic parameters. If you balance all these parameters, your restorations are more predictable. Okay? This is a very good paper. I can pass it on to you. Very good editorial from Frankenberger, Van Meerbirk. I'm going to meet him next year in the meeting here in University of Zurich. He is in the same organization as I am the Secretary General of International Academy of Adhesive Dentistry. It's a small group. I would invite, if you are most welcome, it's a group of 50 top researchers in adhesive dentistry, in which these are the 2 guys who were already in the organization. Now they are in the organization as advisors. And if you read their paper, they say very clearly here, and what they say is when we restore indirectly, we choose bonded partial crowns instead of full crowns, not only in vital, but also in endodontically treated teeth. And this will give you maximal preservation, high predictability, high success rate, okay? Adhesive design concept, this is where dentistry is heading for the next 10 years. It's all ADC. If you follow this concept, you achieve 2 things. You maintain the vitality of the tooth and you maximize conservation of intact hard tissues. So to end on a biomimetic note, the journey of discovery is not based on going to new places, but seeing things with new eyes and your imagination. And I'm sure Edelweiss Dentistry is going to make this happen for all of you. Thank you so much for your undivided attention.